Then our last speaker, Dr. Imalke Kanakananarachchi. He's a senior lecturer and consultant pediatrician, Faculty of Medicine, University of Ruhuna. He will talk about the approach to the child with metabolic acidosis. Over to Dr. Imalke.
Yeah, thank you, Nama. Thank you for the invitation. So I will be discussing the approach to a child with metabolic acidosis, and most of the things have already been dealt by Professor Kavind. So I will be trying to kind of recap what you have learned and go through a few cases. So the objectives wise, I will do a bit of introduction and evaluation of metabolic acidosis, and we'll discuss bit on high anion gap and normal anion gap, but I will not be discussing any management here. I don't think it's within the scope of this lecture. So as we discussed earlier, the normal pH is 7.35 to 7.45. So by definition, acid is a substance that releases hydrogen ion, and a base is a substance that accepts hydrogen ion. So in our body, we have an equilibrium between these acids and base. And by maintaining that equilibrium, we maintain the normal pH. So if the pH is less than 7.35, by definition, we can say it's acidosis. It may be metabolic, it may be respiratory. So we have already discussed this. There are 4 mechanisms how you get acidosis, metabolic acidosis in children. One of the commonest thing is loss of bicarbonate from the body, like diarrhea and renal tubular acidosis. Or else body can produce 3 types of endogenous acids. These are lactic acids, keto acids, and organic acids. Or else body might not produce anything, but from external, you can add some acids. That is what is called the poisoning, salicylates and methanol. And also sometimes when there's renal failure, you can, there's a failure of excretion of acid. So these are the 4 mechanisms behind metabolic acidosis in children. Whenever you get a child, just see which mechanism is there in your particular child. Sometimes some of them may be having more than one. Now you have discussed in detail about this, and I will be going through the rest through some of the case histories. So the clinical features, they can present in acute setup with Kussmaul breathing, and it's as a pediatric emergency. Some of them may be compensated very well. They will be showing signs of failure to thrive and some neurological manifestations. But during our routine investigations only, we will identify them having metabolic acidosis. So these are the clinical features. So as we discussed earlier, the first thing is to calculate the anion gap. In some books, they take potassium also. But usually to say it is normal, less than 12 is the cutoff. But to say it is high, it should be more than 20. So it is always a problem in between 12 to 20. What are we going to how are we going to label it? But it should not only be a number, it should be kind of linked with the clinical history examination and all scenario. And then as we discussed earlier, we need to know the osmolar gap as well. That is the measured serum osmolality with calculated serum osmolality. There can be a difference in between these two. About less than 10 is considered as normal. But if it is more than 15, we consider it as an osmolar gap. So basically, you need to know how to calculate the serum osmolality. For that, you need this. You need electrolyte, you need glucose, you need urea. So for pediatric trainees, you can get data questions. We will be giving these parameters, sodium, potassium, glucose, and urea. And rough idea, 1.86, if you can remember it as 2, then it's easy to calculate the osmolality. But if the measured osmolality is way above the calculated osmolality, that means there are some osmotically active particles other than what we have used in this formula. So that is seen in acute poisoning, but in chronic poisoning, this can be normal. So basically you need two measures. One is anion gap, second one is osmolar gap. Both needs calculations and both have a reference range. Both have a value, both have values when we consider it as high. So if you have a child with high anion gap metabolic acidosis, that means not loss of bicarbonate, you should be able to explain this metabolic acidosis by these three methods. Is it due to lactic acid? Is it due to keto acids? Or is it due to organic acid? Always try to explain your acidosis if it is high anion gap. Out of these three, some patients will have all three. So let's look at. And then it is very important to know when you look at a blood gas, whether this metabolic acidosis is appropriately compensated or not. So we all know when our bicarbonate goes up, our PCO2 should also goes down to compensate. So then it is our duty to know whether this compensation is appropriate or not. Is it inappropriate or is it more than what is expected? So this is the formula. Now this is the third formula I am showing you today. The first formula was how to calculate the anion gap. Second formula was to calculate the calculated osmolarity. Third formula is how to assess the compensation. This is very easy to remember. You take your bicarbonate amount, multiply it by 1.5 plus 8 plus or minus 2. By doing this formula, you can have a child with metabolic acidosis plus respiratory acidosis. That means the PCO2 value has not dropped down to the level we expected. Means even if it is within the normal range, we have to think of a possible respiratory acidosis. This is seen in many conditions in children with acute problems like severe sepsis and ventilator problems. That pattern, even acute severe life-threatening asthma, that kind of. But if you see this pattern, your PCO2 is lower than what it should have been. Again, I'm telling you, PCO2 is lower than what it should have been. If it is the case, that means you have to think of a possible other respiratory stimulant in the body. So that is classically seen in inherited metabolic disorders where hyperammonemia is there, and also neonates who were on furosemide with bronchopulmonary dysplasia. So we will discuss these things later. So basically, if you get a child with metabolic acidosis, you need to know anion gap, if possible a smaller gap, then whether there's appropriate compensation is there or not. Now, this algorithm will help you. If you have metabolic acidosis with normal anion gap, then it's very easy, very few conditions at your level. I think you need to know diarrheal illness and renal tubular acidosis. In this condition, you lose your bicarbonate. But if your diarrhea goes into the level of shock, that is a different mechanism. Then it causes lactic acidosis and high anion gap. But here I am telling only the loss of bicarbonate, how it results in acidosis. When you have high anion gap, it can be divided into ideally two. If there's high osmolar gap and high anion gap, think of acute poisoning. And if the anion gap has no osmolar gap, that means only the anion gap is there, then we are dealing with lots of cases like this. Then you need to know whether this high anion gap due to keto acids, lactic acids, or organic acids. Organic acids are not widely available. Therefore, in basic investigation, you can get an idea what is the main reason. So, if you can explain with high ketone bodies this acidosis, then think of diabetic ketoacidosis and sometimes fasting. But don't try to diagnose diabetic ketoacidosis using this algorithm. You would have had a clear clinical presentation and a the blood sugar level before you apply this. But this is just a theoretical representation. If you think your acidosis can be well explained with lactic acidosis and ketoacids both, that means urine ketone bodies are positive, as well as lactate is also high, then think of organic acidemias and sometimes gluconeogenesis defects like glycogen storage disorders. But if you think your acidosis can only be explained mainly with lactic acid, that may be shock, hypoxia, and mitochondrial condition. So this is the basic algorithm, but there may be lots of exceptions when it comes to real clinical practice. So little bit on lactic acid. Because the normal lactate level you all need to know, because this is something we all worry in our day-to-day practice. Normal value should be less than 1, but up to 2.1 it should be okay. But you would have seen lots of children in day-to-day practice high lactate, but pH is normal. So that condition we call lactemia, or the elevated lactate is there, but no metabolic acidosis. Lactic acidosis by definition means this high lactate should be the reason for metabolic acidosis. High lactate should be the reason for metabolic acidosis. Then how are we going to know that? Now, there's a general principle. If you increase 1 lactate in your blood gas, you drop 1 bicarbonate. So, this is important. As a general rule, the strength of lactate as an acid is similar to that of bicarbonate as a base. So, elevation of lactate causes 1-to-1 decrease in the bicarbonate level. Therefore, acidosis typically becomes concerning around lactate level of 5. Right? You can't explain 7.2 pH with lactate of 3.5. Then it is not due to lactate. So think of organic acid or keto acid. But if your lactate is 10 and your bicarbonate is 12, that can be very well explained because the lower limit of normal bicarbonate is 22. We know increment of 1 lactate drops 1 bicarbonate. So 10 lactate means expected bicarbonate should be 12. So that is compatible. So that is something you need to know. Now, I'm not going to discuss this in detail, but I'm going to show where this lactate is. Now, in the carbohydrate metabolism, you produce a product called pyruvate. Before this pathway, this area doesn't need any oxygen. Even in the absence of oxygen, you generate huge amount of pyruvate. But this pyruvate to go in this tricarboxylic acid cycle to generate energy, you need oxygen. So when you don't have enough oxygen, what happens is this pyruvate will convert to lactate. So that is what happens here, right? So I'm not going to discuss in detail, but some conditions giving dextrose will increase your lactate level in high amount of dextrose, which is not needed for this lecture actually. Right. So the main reasons for high lactate is spurious or the improper sampling. Sometimes hypoxia is I think the second most common, and certain medications which were discussed, and inherited metabolic disorders should be kept as the last differential diagnosis after excluding simple day-to-day practice clinical scenarios, right? Now let's look at this case. 13-month-old presented with cough coryzal symptoms and developed a seizure. Child came to the emergency department. Because of that, they have done some basic investigations. And the pH was lower limit of the normal. CRP was 6. Lactate is 3.8, which is obviously higher than what it should have been. But child looks perfectly well, right? It is only the high lactate, but no acidosis even. So this is likely to be spurious elevation or sampling issue or something like that. And so after some time, child will improve. So do not try to go behind only the lactate, right? So if you are doing lactate, it should be done in a standard setup with the venous. I'm talking about the venous blood, not the capillary blood. Ideally, without a tourniquet, you need to get. And also, if you squeeze a lot to get the blood gas, lots of tissue will get subjected into anaerobic metabolism because of the squeezing. It increases the high lactate level. So if you have a child with relatively well and no other concerns and no metabolic acidosis, lactate less than 4, forget about it. Now this one, this is a true case. There's a consanguinity. This baby, around 8 days, admitted to the emergency department with a pulse rate of 170. All the peripheral pulse were weak because of we were thinking of possible shock. That is the reason for weak pulse, and the pH was 6.8 and very high lactate. You can see bicarbonate was 7, lactate was 10. And there was hypoglycemia as well. Because of this consanguinity thing, and they were thinking of possible inherited metabolic disorders as well, but started empirical treatment. So thinking of sepsis, nothing much to suggest here. And metabolic acidosis wise, metabolic wise, lactic acidosis without shock or hypoxia, and mild hypoglycemia, consanguineous parent, these are in favor of metabolic, right? And ammonia was slightly high, which is normal for this age. And then the cardiac, yes, this child after resuscitation, we felt that child has got weak femoral pulse. And then later on, the diagnosis was made as coarctation. But even if you think of a metabolic condition, think of a common conditions at the beginning. So this is coarctation of aorta resulting in shock, right? So I'm not going to discuss this part. Now this case is very commonly encountered case. This venous blood gas was sent to me by a pediatrician in a peripheral hospital. A 10-year-old asthmatic presented to the emergency department with shortness of breath and tachypneic, tachycardic, and saturation was so low. Child was given standard treatment for asthma, and you can see the pH is 7.436. Lactate is 6.5, right? And so some amount may be from the collection of the sample, but this is something you need to remember. High lactate, sometimes it can cause, it can result in acidosis also, not only high lactate. It is a feature of asthma. Asthma in the sense, beta agonist. So there are a few mechanisms why salbutamol results in lactic acidosis. If you see some of these patients, it is not seen in all patients. It is not dose dependent. I think there are some genetic predisposition as well. Certain children will show lactic acidosis just because of salbutamol nebulization. The reasons are these beta agonists stimulate lipolysis and free fatty acids, and it inhibits pyruvate. And also use of steroids on top of salbutamol can increase the sensitivity of beta-2 receptors and further potentiating lactate production. And also stimulation of glycolysis and glycogenolysis through other catecholamine surgery, because these are beta agonists. Beta agonist means you increase the sympathetic drive. So another cause of acidosis, right? Now this case, 13-month-old, present third child of consanguineous parents. Unexplained sibling death is there. There's hypoglycemia and ketone bodies positivity. And you can see severe metabolic acidosis, 7.1. This is the child before the admission. And after a few days later, you can see how neurologically disabled this child. These are the neuroimaging findings. I'm not going to discuss. There are some changes in the brain, in the thalamic area. So you can see lactate is 4.2. Now I will take this as a case to evaluate how are we going to approach this child. You assume that you are in a setting where you don't have any other investigation other than a basic investigation that I have already shown. So what is the anion gap? So sodium 142 and potassium 4, chloride is this much. Then you can see anion gap is high. Now we need to think whether this is a ketone body induced acidosis, lactic acid induced acidosis, or else organic acid induced acidosis, or else a mixed. Let's look at. Now then you need to know whether the compensation is appropriate or not. Now the bicarbonate is 8 and PCO2 is 12. Now let's see whether it is appropriate or not. Now with this formula, your expected PCO2 should be 24 to 28. But in this child, it is 12. That means there is an overcompensation. So then what is the overcompensation? So highly likely in the background of consanguinity and the sibling death and the ketone body positivity and the hypoglycemia, the possible respiratory stimulant could be ammonia. But you don't have ammonia measurements in your hospital, but think like this, it is most of the time true. So ammonia may be the thing. So then we need to know, is this acidosis due to lactate or not? I told you elevation of 1 lactate causes 1-to-1 decrease in bicarbonate. So 4.2 lactate means the bicarbonate should have been somewhere around 18 like. But here it is 8. That means other than lactate, some other acidotic particles are there inside the body. We all know now ketone bodies are positive. That means another acid, keto acid. And also with the high ammonia, organic acid. These investigations are sufficient enough for you to manage this child as for a case of suspected organic acidemia in a peripheral hospital to manage with dextrose, bicarbonate, and you can even start ammonia scavengers to save the life of the child rather than wait until we get ammonia level. So most likely organic acidemia. This is a child with methylmalonic acidemia. So these are some of the patients following up in the clinic with organic acidemia. They are there. We sometimes miss these diagnoses. So last few things, if I mention few diseases that can present with lactic acidosis in children, there are two main types. The first type is lactate might goes up as a secondary phenomena when most of the organs damage, like in organic acidemias and fatty acid oxidation defects, or else some metabolic disorders which affects mainly the mitochondria can result in lactic acidosis due to the defects in TCA cycle. I'm not going to discuss in detail, but in a child with metabolic acidosis, when to suspect inherited metabolic disorders, think about the previous case. Consanguinity may be there, and the overcompensation may be there, or else respiratory alkalosis may also be there on top of acidosis. Now the last case, this baby is now I think around 1.5 years. Like this baby at the age of 3 months presented with failure to thrive, and mother was happy about the urine output, and there's significant weight faltering. You can see there's significant acidosis, and chloride level, you can see chloride is 110. The moment you see someone with acidosis with high chloride, then think of normal anion gap. And this child's anion gap, if you calculate 135 plus 843 minus, 135 minus 110, 25, 25 minus 8 means definitely the anion gap is less than the high anion gap level. That means it is less than 20. And the rest of the investigations are normal, and the ultrasound scan shows bilateral nephrocalcinosis. So having normal urine output in a child with failure to thrive, I am concerned because it may be polyuria, right? So this is a child with distal renal tubular acidosis. So the key feature in the history was there's some polyuria and metabolic acidosis with high chloride. Even if you don't calculate the anion gap, high chloride will give a clue. So coming back to the previous algorithm, now this is a case which is compatible with this arm of the algorithm. So there's normal anion gap and diarrhea or renal tubular acidosis. So this table is from your Nelson, how to differentiate 3 types of renal tubular acidosis based on the potassium value, urine pH, and the rest. I'm not going to discuss this, but type 4 renal tubular acidosis, potassium is high. Other types, potassium is low, and urine pH is helpful to differentiate proximal from distal. And the nephrocalcinosis is a feature in classical distal RT. So the take-home message, anion gap and osmolar gaps are important in evaluating a child with metabolic acidosis. Always look for the appropriate PCO2 compensation to identify underlying respiratory alkalosis and respiratory acidosis. Improper sampling results in spurious elevation of lactate. To cause acidosis, your lactate should be at least more than 5. Inherited metabolic disorders should be suspected when the lactate is persistently elevate more than 10. This is inherited metabolic or the mitochondrial diseases, because other metabolic diseases can have even with low amount of lactate, but the reason for acidosis may not only be the lactate. Lactate can go up in number of metabolic disorders with keto acids and organic acids. And when someone present with normal anion gap metabolic acidosis, RTA should be kept in your mind. So these are the take-home messages. I think that's it. If there are any questions, I'm happy to answer.
Okay, thank you very much, Dr. Imalke.